Welcome to The Explainer. Okay, let's just jump right in. Picture this. You're a first responder, you arrive at a scene, and it is pure chaos. You've got a patient who's agitated, maybe even violent. What's the move? Well, there's absolutely no time for guesswork. So today, we're going to break down the highest stakes protocol these medics follow, from that very first assessment all the way to the critical decision to sedate.
And that question, right there, really gets to the heart of what emergency response is all about. In a moment of just total chaos, instinct alone is not going to cut it. Paramedics have to rely on a really strict, predefined plan to bring some kind of order to a situation that is completely unpredictable. So let's walk through what that plan actually looks like.
All right, so let's really put ourselves there. The scene is tense, right? It's high stress, it's unpredictable, and frankly, it's potentially dangerous for literally everyone involved. A structured protocol in a moment like this, it's not just some friendly suggestions. No way. It's a lifeline. It's designed specifically to bring order and safety to a really volatile situation.
Okay, first things first. The protocol doesn't just jump to restraining or sedating someone. Nope. The very first step is to investigate. Medics basically have to become detectives on the spot. Before they do anything else, they have to figure out the why behind what's happening.
So what does that look like? Well, they're immediately running through this mental checklist, just trying to gather clues. Things like, is there a known medical history? Are they supposed to be on any meds? And hey, is there anyone else here, family, friends, who can give us some context? Literally every single piece of information is absolutely critical in these first few moments.
And while they're digging for that history, they're also observing what's happening right now. Is the person making threats? Are we talking physical violence, or is it more agitation? Are their actions putting themselves or the crew in danger? Each one of these observations is just another key piece of this puzzle they're trying to solve.
And this is where we hit a really critical fork in the road. What if the agitation isn't a psychological issue at all? What if it's physiological? It could be anything from a hidden head injury to a severe diabetic episode, maybe even a reaction to a drug. And think about it. Treating the agitation without finding that underlying medical cause, that could be a fatal mistake. So ruling these other possibilities out is an absolute top priority.
All right, so once they've considered those medical causes, the protocol shifts gears into direct intervention. But, and this is key, it doesn't just jump straight to the most extreme option. Instead, it builds what's known as a de-escalation ladder. It's this really measured, step-by-step response that always starts on the lowest possible rung.
So what's that first rung? It's always verbal, just talking. Can simple reassurance calm the person down? If that doesn't work, okay, next step, let's bring in other people. Can a family member, a friend, maybe help de-escalate things? It's only when both of those options are completely exhausted that the protocol allows for the last resort, physical restraint.
But what happens when someone is so agitated that talking is impossible? Or when physical restraints are failing? Or maybe even making the situation more dangerous? Well, this brings us to what is probably the most critical decision point in this entire protocol: the choice to use chemical sedation.
Now, the protocol is really clear here. It gives two very specific justifications for sedation. The first one is pretty obvious, right? The patient is violent and a direct threat to themselves or others. But the second reason is a little more subtle, and it's just as important. It's when the patient's agitation is so severe that it's physically preventing the medics from providing other potentially life-saving care.
Okay, so when we're talking about overt violence, the protocol calls for a sedative called midazolam. And the dosage isn't a guess, it's incredibly specific. It's calculated by weight, and it has a strict maximum limit. These rigid numbers are there for a reason. They're a safety mechanism designed to stop anyone from just guessing and potentially causing an overdose in a super high-stress moment.
And this is where you really see the nuance in the protocol. If the goal isn't to stop violence, but just to calm the patient down enough so you can treat them, guess what? The dose of midazolam is cut in half. The philosophy behind this is crystal clear. Use the absolute minimum dose needed to get the job done. And the job is providing care, not just knocking the patient out.
The protocol also has these critical safeguards built right in. For example, for elderly patients and for kids, all those doses we just talked about, they're automatically cut in half. And for very young children, medics can't even act on their own. They have to contact a doctor to get orders. Plus, there are explicit warnings for patients who might be at risk for things like low blood pressure or breathing problems, because the sedative can actually make those things worse.
This quote here is pulled straight from the guidelines, and wow, it is a stark warning. Sedating someone who might have a head injury is incredibly risky, mainly because the sedation can hide symptoms that are getting worse.
It's a powerful reminder that even with a super strict protocol, a medic's clinical judgment is still absolutely paramount.
So, okay, the patient is safely sedated, the crisis is over, right? Wrong. Absolutely not. As soon as the patient is stabilized, the protocol shifts into a whole new phase, one that's just as important: obsessive, constant monitoring to make sure they stay safe. And this really shows you that sedation isn't the end of the line. It's the beginning of a period of really intense monitoring. Medics immediately get a full set of vitals, they give oxygen, they get an IV started, and they hook the patient up to advanced cardiac and respiratory monitors. The immediate threat is gone, so now the focus shifts 100% to the patient's medical stability.
And we're not talking about a one-and-done check here. The protocol mandates this relentless reassessment clock. Every 5 minutes, boom, new vitals. If restraints are being used, every 15 minutes you're checking circulation. The whole point of this is to catch any potential complication the very second it starts to happen.
So when you step back and look at this entire process, from start to finish, a really clear philosophy starts to emerge. From the very first words of reassurance to that final check of the vital signs, none of this is actually about control. It's about creating a bubble of safety, a safe space where medics can finally do their real job, which is to provide medical care.
And that kind of leaves us with one final thought to chew on. In the middle of all that chaos, in the heat of an emergency, does a rigid step-by-step plan like this actually tie a medic's hands? Or does it do the opposite? Does it liberate them from having to guess, freeing up all their mental energy to just focus on taking care of the patient? It's a really fascinating question, isn't it? All about how experts perform under extreme pressure.